Wonderful. Okay, so Rick, thank you so much. We were on a couple calls over the past 24, 36 something hours. All the days are blending together. We really appreciate you being here with us and sort of taking it home for us with an ultimate keynote. I know you got a screen share that you're trying to do there, so you just let us know when you've got that sorted out, and I will turn my camera off so nobody else has to see my face. And just to the audience, thank you very, very, very much for your patience, your kindness. We've learned a lot along this process. We have a lot of takeaways. It was a lot of it was on the fly. This is a new platform to many of us. Connor over here, looking at you, bud, tech support. He did a fantastic job. So, if anyone wants to give him a shout out in the comments, feel free. I wouldn't have gotten away with any of this without him. He's tech support, ultimate tech support. He figured out how to get Rick's audio working, that's for sure.
When I try to share the screen, it doesn't share the screen. It shares this with Facebook, Twitter, LinkedIn. So I'm not.
Okay, Connor, what are we looking at there?
If you hover over yourself,
there's tech support.
If you hover over yourself, are you talking about that share screen where you're like toggle video, toggle mic?
It might be in the top right.
Yeah.
Well, the top right there's a share with an angle.
Go to your video screen. There should be a share in your video screen.
Yeah, and then put share screen in there.
Great. Okay.
See, look at that. Tech support.
Gotcha.
Go, Connor.
Okay. Closing keynote, I guess. Launch. Let's see. Entire screen.
Beautiful.
I think this is. Oh, wait a second. Sorry.
Yeah. No, that's okay. Yeah, we're doing it live. It's all good.
Yeah. Let's just
right on. Okay, so we've got you minimized there.
Okay. Do you see the PowerPoint in wide angle? I mean, all the in the.
I'm not seeing it yet.
Okay, so how do we do this? Okay, so share screen.
Yeah.
It says window or screen to share. Select window or screen. Launch application, closing keynote, or entire.
Yes, correct. Yeah, you're gonna want that.
Okay. Allow.
Yeah.
No devices were found to provide the media stream. You can still hear me?
Oh, we can still hear you. Oh yeah, for sure.
Okay, so now let's just.
Michael, I think Connor agrees.
What do I have to do?
No, let's fix it.
Why can't you share the screen?
Can you see it now?
No.
Can you see it now?
Not yet.
Darn it. Okay, that's let's see. All right, and show.
Share screen. Yeah, I think you click on the screen that you want to share.
Yeah.
Application window, and then you click the application window and you click share.
Or you just
all right, so yeah, we should be able to figure this out. So the image of me, there's something that does say share screen.
Yeah, so click that.
Okay, then it says, will you allow Crowdcast to see your screen?
Please do.
It says select window or screen.
Okay, so window probably. Application.
Launch application, closing keynote, or entire screen.
And then at the bottom right, you should see share. If you go application window, closing keynote.
Okay, closing window. Okay, then it's allow. Closing keynote. Now it says no camera, microphone. Sorry for this.
No worries. This has been the easiest we've had it all conference.
Okay, so now if you can't see my screen, you just see me.
Maybe just do your entire screen and then.
Yeah, entire screen's easier.
Okay, we'll try that. Okay.
Yeah, we'll go your presentation.
Entire screen, allow.
Yeah.
Still get no microphone, but you see the.
That's okay because we can still hear you. I'm pretty sure.
Okay.
So.
Okay. Can you see the screen now?
Not quite yet.
Oh, so close. Probably. I don't know.
This is right. Okay, so that didn't seem to work then. Share screen.
Oh, you know what, Rick? Why don't you email that presentation to me?
Yeah, we can share it.
Oh, that'll take a few minutes only because it's long. I'll have to load it up to Dropbox and then send it to you. It'll just take a few minutes, but I can do that for sure.
Sure. Yeah. Why don't we do that? We can guarantee it on our end.
And then, do you do the advancing, or would I do it?
So Connor actually is a great dancer.
I'm sure you can talk for 5 minutes and educate yourself.
You know what? Let's.
Could we try one more time just to see?
Let's try it. Yeah, for sure.
Only because I can go through it a lot faster if.
That's much easier.
But,
So share screen and then allow, and just nothing happened.
Thank you, Joy.
No,
if we can create conversation in the chat, like what do we want to talk about, guys? Give me
I could always do it without the PowerPoint too, but there's a lot of good things in there.
So let's figure out the PowerPoint. Yeah, let's. Well, Emily, we're very excited for the Zoom party as well.
All right.
And on the bright side, there's only 158 people watching now, but we can cut this all out of the recording. So later, the other 900, and I can't do math, they won't even see this.
840.
Yeah, whatever that is. No, it's 157 now.
Let me.
Kevin L. Yes, that is exactly it. Starting it live, ending it live, or doing it live. Goya, Alana wants to know how you maintain such a positive attitude. Can you get an answer to that?
I'm not in jail.
You know what? The work. They work.
Okay.
Craig, I think it was a dancing presentation, but could be wrong.
Oh, gosh. Let's see here.
Yeah, maybe just email it to us there, Rick. We'll get it sorted for you.
Yeah. Okay.
Yeah. He has been keeping the positive attitude for the past 40 years. Correct. Definitely. Alex, not yet. Not anymore.
To save it for my desktop. Can you let's see.
Rick,
can you load it? Yeah.
Yeah. No, go ahead. Sorry.
Okay. We're trying to load it up to Dropbox right now.
Yeah, okay. If you just send us, or you can even just send it in an email, a direct email. It's probably not that big.
No, it's way too big. It's too big.
Okay, yeah.
Dropbox is.
And where should we send it? Which email would you like? Could you
send it to patrick@alanaldis.com. You'll have me in there from our previous correspondence.
Okay. Yeah. So
Barry, it's not a single malt. I don't know. What is this, Connor? Ryan Ginger.
And then we'll send it to Patrick.
Yeah. Yeah, Shane is definitely not driving us tonight. Holy cow. What else do we have here? Shoheen, wait, sorry, who wrote this? Yeah, Shoheen would like you to know, Rick, that he loves you. And also Troy would like to know if you're going to join us in the after party. I think people want to see that sick bong get taken for a rip.
I've got it set up.
Well, I will for a period of time then, yes.
All right, yeah. Rick is going to rip bongs with us. Emily Fuster, I'm not going to lie. That's Connor's drink of choice. Not mine. I'm a beer guy.
Hey,
beer or tequila.
it's delicious.
It is. It's delicious. I'm not. There's no complaints here. Barry, don't you be disappointed in me. Get out of here.
Oh,
that's like
my side. Okay,
it's like a dagger in my heart.
Yeah. That's all.
Rick, Alana feels bad for telling you not to eat. What did you want to eat for dinner? What were you going to eat for dinner? Just kidding.
No, Rick.
Okay.
All right, we got a PowerPoint, ladies and gentlemen.
Okay, let's see if it's gonna work.
All right, we're gonna share. I'm gonna open this up in a new tab.
Yeah, and then share your screen.
Bingo, sure am. What do you think? I need tech support?
Sometimes.
Yeah, all the time. All right.
Okay.
All right. Share screen, application window,
Just
PowerPoint, share. We got ourselves a PowerPoint, ladies and gentlemen. Yeah.
All right. Okay.
All right. Rick, you're going to need to just say.
Tell us when to flip.
Yeah, well, I was going to make up a fun word, but just tell us when to flip. Yeah, call call it a hippie flip. Say hippie flip when you want us to switch slides.
Well, that'll be too long. I'll just try next. But
all right, fine. Who's next? Okay, and the floor is yours. Thanks so much, Rick.
Okay, thank you. Sorry for everybody for all these delays, but next would be the one. So I think we really need to all acknowledge the debt of incredible gratitude towards Stan Grof. He said psychedelics are the study of the mind, what the microscope is to biology and the telescope is to astronomy. Stan is really my mentor. He's the one that really kept the psychedelic movement alive when everything was crushed and the backlash, and he then found a way to develop holotropic breath work as a way to catalyze experiences that were like psychedelics. So he attracted all the advocates for psychedelics, and I was also one of the ones that was trained with him in the breath work. And he never went along and said, "Oh, psychedelics were just something I used, and now I'm meditating, or now I'm doing yoga." He always held to the value of psychedelics. So really, if there's a chain, it really goes from Stan. So Stan's just been tremendous in how he's really kept this whole thing alive. And next. So there's a lot of catalysts of senses of global interconnectedness. On the left is the coronavirus, on the right is global warming, in the middle is the LSD molecule. And so we really need this. The upside, you could say, of global warming and corona is that we are realizing how we're also interconnected, but there's a lot of pain and suffering that goes along with that, and a lot better way to do this would be just to have people have LSD and psychedelic experiences. Next. There's another way to get this sense of global interconnectedness. That's going up in space and seeing the Earth from space. Edgar Mitchell said, when we see our fundamental unity with the processes of nature and the functioning of the universe, as I so vividly saw it from the Apollo spacecraft, the old ways of thinking and behaving will disappear. Of course, we can't afford to send everybody up in space. Next. The kind of transition that we're talking about, this thinking in a new way that Edgar Mitchell talked about, Abraham Maslow, who helped start humanistic psychology, a lot of people have learned this in school about the hierarchy of needs, which goes up to self-actualization. And near the end of his life, though, Abraham Maslow changed this after having a lot of confrontation and acknowledge and interest and education with people who are doing psychedelic research. Next, please. And so he ended up putting something over self-actualization. So the next slide. And that's self-transcendence. So that's service to others as well as to yourself. And so I think that's the transition that individuals make. That's the transition that our culture needs to make. And that's where we think that psychedelics can play a role in that transition. They're not the only way, but they're one of the most important ways that have been used for thousands of years. Next, please. Now, in addition to this sort of mystical sense of connection, psychedelics can be helping us heal trauma, multi-generational trauma. This is Richard Rockefeller and Larry Brilliant at a talk in 2013. And also all sorts of other therapeutic aspects of psychedelics. That's what we're talking about when we talk about medicalizing psychedelics. So not only spirituality, but a lot of emotional trauma and illnesses we can change. And so as well as all sorts of inspirational experiences. So that's really the importance of psychedelic research. Next, please. And what I'm showing you here is a kind of psychedelic slide. And the importance here is that this was a slide created by the FDA. This was May 30th, 2019 at the American Society for Clinical Psychopharmacology. And at this conference, this was a group of FDA people started coming informally outside of their FDA context, but they presented their information, they presented this slide, and they announced that they're going to be working on a guidance document for the development of psychedelic studies. And so this will be a guidance to help future sponsors. So the FDA is really an ally. Earlier, I said the key turning point was 1992 when the FDA opened up the door to research, and they are still very supportive, science over politics. And it's because of the FDA that we have the psychedelic renaissance going on now all over the world. Now, another part of society, next, please. This is actually astonishing. This was my TED talk. And when I went to check on it, it turned out that the National Security Agency was advertising. I surely have a deal with TED, but I don't know if they are aware of this, or did they think that people who are interested in psychedelics are more interested in going to work for the NSA or the CIA or something like that. But this is just another indication of cultural change. Next, please. And then this is, for me, one of my favorite indications. This is Salko Gregarian, and he's a police officer who's actually a psychotherapist. He works to help other police officers, and he's now going through our training program in order to learn how to do MDMA-assisted psychotherapy with police officers with trauma. And he's actually arranged meetings with his police chief, with other police chiefs, and before COVID canceled things, he'd arranged for 100 police officers who are involved in the rapid response for various crimes and traumas that they were going to hear about MDMA. So that'll happen later, but this is just one more indication of social change. Next, please. So this is what the structure of MAPS. MAPS is the nonprofit, started in April 2000, started in April 1986. And in December 2014, we started the MAPS Public Benefit Corporation. That's when we realized that there would be a potential, if we make MDMA into a medicine, in order to sell it for a profit. And that's something that could not be kept inside the nonprofit. It had to be taxable. And so we created the MAPS Public Benefit Corporation. So what we're trying to do is basically two different things. One is to bring forth psychedelic-assisted psychotherapy as first in class with MDMA-assisted psychotherapy, but to open up the whole field for psychedelic-assisted psychotherapy. But we're also trying to model a new way of marketing drugs. There have been some other benefit corps for pharmaceutical companies, but we're going to try to market it maximizing public benefit, not profits. And what made the Public Benefit Corporation possible, next slide, is that, next please. So in, MDMA was invented in 1912, so it's off patent. And in 1984, Ronald Reagan signed a bill into law that provided incentives for developing drugs that are off patent. And these incentives are called data exclusivity. And so what that means is that if you are the first sponsor to make a drug into a medicine that's approved for prescription use, nobody can use your data for a period of 5 years to market a generic. And if you do pediatric studies, which we've been talking about, then you get an extra 6 months extension on the data exclusivity, and then it blocks a generic manufacturer from applying to market a generic until this 5.5 years is over, and it takes FDA at least 6 months to evaluate. So we anticipate somewhere in the neighborhood of 6 years data exclusivity. In Europe, it's 10 years. And the beauty of this is that it doesn't require any patents, anything to be kept private. We can share all of our data. We don't use non-disclosure agreements. There's no need for any of that. We just have to be the first to present the data to the FDA. And this is going to be the same story for Compass, for psilocybin, for Usona, for psilocybin. And so what that means is that you have exclusive use of your own data, but you can generate their own data. So if somebody else wanted to make MDMA into a medicine for PTSD, they could do so. So that's the way data exclusivity is different than a patent. Next, please. So in addition to MDMA-assisted psychotherapy for PTSD, I just wanted to mention that we are working to try to bring Ibogaine a pre-IND meeting with FDA. Now, I'm aware that Atai has purchased patents from Deborah Mash, and Atai and Demorax are going to be working together to develop Ibogaine into a medicine. The core patent on Ibogaine for opiate addiction has expired. It's in the public domain. And what I've realized is that the work that we will do will benefit everybody. We are in favor of Atai moving forward with Ibogaine, and we wish them well. They have more access to resources than we do right now. But whatever we do will be in the public domain and will help everybody. Next. We're also going to be applying for money from the state of Michigan for marijuana research for PTSD. So in the legalization of marijuana for recreational use in Michigan, there was this provision that was included in the act that the state of Michigan must spend $20 million a year for 2 years for FDA-approved clinical trials. They must be sponsored by a nonprofit or university-based researchers, and they must study the efficacy of marijuana in U.S. armed service veterans and in preventing veteran suicide. So we're working on a protocol to develop. Probably we think they'll put this money out near the end of 2020 or so. But those are the two main things that we're doing other than MDMA-assisted psychotherapy for PTSD. Next, please. And we're also on the verge of suing the Attorney General. We're also going to be submitting some comments to the DEA because the thing that has really blocked cannabis for marijuana from becoming a medicine in the U.S. in flower form, we do have GW Pharmaceuticals, Epidiolex, is that there's been a government monopoly. The University of Mississippi is the only organization that has a DEA license to grow marijuana for research, and their marijuana cannot be used for commercial sales. It's only for research. And phase 3 research, you have to use the exact same drug you want to market. So this monopoly is on its last legs, but it hasn't ended yet. We need to encourage Attorney General Barr to end the monopoly. So that's another thing that we're doing. We've been working on that since 2000, trying to end the NIDA monopoly. And there's a May 22nd is when the comment period has to go in on the DEA's suggestion for other things. So MAPS, yeah, next slide, please. Yes, so just to say that MAPS has a whole series of things that we're doing. Communications, fundraising, media, education events, operations, Zendo, advocacy, policy and advocacy, our leadership team. And next slide, please. But the Benefit Corp, which is the next slide, is about twice as large as MAPS in terms of the number of people. So this is led by Amy Emerson, a bunch of, this is a female leadership team, many of them from Novartis. And so this is the operational aspect of making a drug into a medicine. And the one thing that we did here that's important to note is that I'm not sure exactly how a lot of these Mind Medicine, other companies that are going to be doing this, but they are likely to be hiring CROs, contract research organizations, to conduct the actual research. I don't know if a lot of these groups will have their own internal staff to conduct research, but it's a lot more expensive when you hire others in a CRO. So we decided at a very early stage that we would do this all internally. So this is our internal drug development team. Next, please. And in addition to that, we have our principal investigators, our therapists who are training others, and we've got, well, several hundred therapists that we've trained as well. So that gives you a sense of what MAPS is. Next, please. So over the course of MAPS's 34-year history, we've raised over $80 million. And when we added it up, I was actually astonished. That's an awful lot of money. All of that is charitable donations. It is over 34 years, but most of it has just been in the last couple of years, because for the first bunch of years, we didn't need much money because the FDA was saying no to everything. Then the studies were relatively small. It's only now that we're really scaling up to phase 3 that we need a whole bunch of money. And the important point now about the fundraising, next slide, please, is that we have a bipartisan group of donors. So Rebecca Mercer, whose family was the main funder for Trump and Bannon, they owned Cambridge Analytica, Breitbart, they're big minority shareholders in Breitbart. But Rebecca gave us $1 million. The only restriction was that it go to veterans. And we were very glad to be working with her on that. Next slide, please. We've also received a pledge from Elizabeth Koch of $900,000 a year for 3 years for our GMP MDMA. She's the daughter of Charles Koch. So again, this kind of range of donors. Next, please. and George Soros and the Open Society Foundation. And we have the Rockefellers, the Pritzkers, all sorts of other donors as well. But this is just to show that really helping heal trauma is not a left-wing or a right-wing issue. It's really something that we've been able to get support from everybody, and I think it's extremely important that it really is bipartisan in that way. Next slide, please. So this was, I talked about a bit before, in 1984. This is me in that picture right before I walked into the DEA headquarters to file for a lawsuit to try to protect therapeutic use of MDMA. Next slide, please. We ended up winning that lawsuit. The judge said MDMA should be Schedule III, but the DEA rejected the recommendation. And then we sued a couple times in the appeals courts and won. Then we lost eventually, and that's where I realized we needed science, medicine, and so I started MAPS's nonprofit pharmaceutical company to go through the FDA in 1986. Next slide, please. And so 30 years later, just skip all the history for you, but it took us 30 years, basically 30 and a half actually, to have what's called an end of phase 2 meeting with FDA. And that's where you are presenting your phase 2 data and you ask for permission to go to phase 3. Next slide, please. This is the data that we presented to the FDA. We have a control group. We're comparing therapy with MDMA versus therapy with either inactive MDMA or very low dose MDMA. And we work with people on average severe PTSD, chronic, severe treatment resistant PTSD. In the phase 2 studies, everybody was treatment resistant. And we got 23% of the people at the 2-month follow-up after the last experimental session. 23% of the people who were in the control group no longer had PTSD. So what that is basically showing is that that's comparable to other non-drug psychotherapies, but it also shows that we're really trying hard even when it's the control group. Next slide, please. So when you add MDMA, though, the results more than double. 56% at the 2-month follow-up no longer have PTSD. And that's really great. So what that really shows is that the MDMA more than doubles the effectiveness of the psychotherapy. Next slide, please. And this is, I'd say, the most important slide of our results. What this shows is this is the 1-year follow-up. And what this indicates is that people keep getting better. They are learning how to process trauma, learning not to suppress their emotions. And so the concern has been, look, you put in all this energy and time into people, and is there this psychedelic afterglow? Does it fade over time? What we're showing is that people are actually getting better over time. And that's the beautiful part of this. So 2/3 no longer have PTSD. And of the 1/3 that does have PTSD still, almost all of them, but not all of them, have had clinically significant reductions in their PTSD symptoms. And if they could have had 1 or 2 more MDMA sessions, maybe they would no longer have PTSD. But there are some people, you have to be willing to do the painful work, and so it's not going to work with everybody, but it's really pretty remarkable. Next slide, please. So this is just what our treatment is. It's about 18 weeks. There's screening. Basically, the yellow circles, there's 3 8-hour-long MDMA sessions with a male-female co-therapy team, and then in most cases, people spend the night in the treatment center. And there's 12 90-minute non-drug psychotherapy sessions as well. So it's overall about 42 hours of therapy. So it's intensive psychotherapy, but these are the hardest cases. There's 3 non-drug psychotherapy sessions for preparation, for building the therapeutic alliance, for preparing people for MDMA. And then there's 3 90-minute integration sessions after each MDMA session. And the MDMA sessions are 3 to 5 weeks apart. And then the end of treatment is the outcome measure is 2 months after the last session. So we're specifically trying to get away from this psychedelic afterglow and try to show, is it really durable? and the FDA is going to look at the 2-month outcomes. The insurance companies will look more at the 1-year outcomes to see if it's durable. Next slide, please. And so the key elements of our therapy are that it's inner-directed. We believe that basically we're helping people heal themselves. The best metaphor for this is midwives, that we're helping people heal themselves. I just saw a question about the dose. So I'll just say that the first session is going to be 80 milligrams, and then 2 hours later, between 1.5 and 2.5 hours later, we give an additional 40 milligrams, half the initial dose, to extend the plateau of this optimal arousal zone, of the optimal zone for doing therapy. The second and third MDMA sessions are going to be an option, either, and this will be a discussion between the therapist and the patient, either they stay at the 80 milligrams and then the 40 milligram supplemental, or they go up to 120 with a 60 milligram supplemental. So we anticipate that most everybody will go in the second session up to the 120 over 60, and then the third will be more of a discussion between, again, the therapist and the patients, and that'll either be the 80 and 40 or the 120 and 60, and the supplemental doses are also optional. So there is some kind of a titration per patient permitted. Next slide, please. So the key thing is that this is inner-directed, non-directive. We support what's emerging. We believe our hypothesis, this inner healing intelligence. People recline. You can see headphones with music. For MDMA, roughly half the time is spent people going inward. The other half is with interactions with the therapist. This is this alternating inner focus and talking to therapists. However, for LSD or psilocybin, it's more like 80 or 90% or so. People's eyes are closed with a lot less interaction with the therapist. With those drugs, it's more about the integration process, the preparation, and supporting people while they're going through those ego dissolution experiences. For MDMA, there's a lot of value that comes from the therapeutic interaction, from people telling their stories. So that's, and you can go to the maps.org, the treatment manual. So again, that's all in the public domain. We're not patenting our treatment approach or trademarking or anything like that. Next slide, please. And this is an important distinction that needs to be made. I just see a question. There does not need to be a physician present, although we're negotiating that with the FDA for a future. This slide is important, though. You may have heard that for all the work with LSD, psilocybin in the 60s and 50s, and also the recent work with the classic psychedelics, that there's a correlation between the depth of the mystical experience and therapeutic outcome. And what it turns out, though, is we use the same measure, the mystical experience questionnaire, with MDMA. People score remarkably high on it, but that there is no correlation between the mystical experience and therapeutic outcome when it comes to PTSD with MDMA. So that suggests, again, how we do the therapy. We're not aiming for the mystical experience. We're supporting whatever emerges. People may have it, they may not. It's more about confronting the trauma, working through that, and expressing your emotions. Next slide, please. So on the basis of that, FDA said, yes, we could move to phase 3. New York Times reported it. Next slide. Next slide, please. So this is really important. We engaged for about 8 months in a special protocol assessment process. We negotiated every aspect of the protocol design, the statistical analysis plan, all the other information FDA's wanted to see, and we came to agreement. We have an agreement letter in the special protocol assessment process. So FDA is legally bound to approve the drug if we get statistically significant evidence and no new safety problems arise. Next, please. This is actually more important than breakthrough therapy, which we also received in August 2017. This gets you expedited review times, more meetings with FDA. It's important, but it's not as important really as the agreement in the special protocol assessment, where we've reduced all sorts of uncertainty because we've negotiated all the aspects of the protocol with FDA. Next slide, please. These are going to be the phase 3 sites. We have 15 phase 3 sites, 2 in Israel, 2 in Canada, and 11 throughout the United States. Next slide, please. After we reached all these agreements and got breakthrough therapy and special protocol assessment from FDA, we went to the European Medicines Agency and we negotiated with them their scientific advice meeting. We got approval for them to go to phase 3. Next slide, please. And these are the 7 countries that we're now going to be doing our research in Europe. And we are all shut down, of course, there because of COVID. Europe is about 2 years behind the US, and we're still at the stage of getting the early protocols approved and starting to or complete the training of the therapists. Next, please. In the US, we also did get expanded access. That's kind of very important. Compassionate use. There's 8 million PTSD patients in America. We're only going to have around 200 in phase 3. And so expanded access is a compassionate use program. And what that permits is patients to pay for it themselves. And it enables us to train more therapists. And the FDA doesn't look at that data for approval. And so we are very interested in starting this. We'll probably start it September, October, depends on when we can go back to work. And then we've only been approved for 50 patients. And then next summer, hopefully or a little bit after that, we'll be able to go back to the FDA to increase the number based on the data we submit. And this is also real world evidence in a sense. People can stop after 1 session, after 2, after 3, because they're all paying for it. So next slide, please. And so where we're at with phase 3, we do with FDA 2 100-person studies. We have enrolled all 100 of the first study. Now, not all of them have started treatment. Not all of them have completed treatment. Things have been interrupted by COVID, but we have enough people that are treated in the pipeline that we'll have about 75 or so participants will have completed their primary outcome measure despite COVID, and then we'll have to see about the remaining ones. Next slide, please. And so we were permitted to do an interim analysis where 60% or 60 people had reached their primary outcome measure, all 100 had been enrolled. And so we're going to be reporting the results of the interim analysis. Since I'm the keynote, I'll also say that the opening talk by Robin Carhart-Harris, he talked about the study that they did that was comparing psilocybin for depression with regular antidepressants, but he didn't share the results because they're trying to get it published or so on. So similarly, I can't share the results of this quite yet either. Next slide, please. But I do want to share the results of Tonix Pharmaceuticals. So there's only 2 drugs that have been given breakthrough therapy by FDA for PTSD. One is ours, MDMA, and the other was a drug called Tonmya by Tonix Pharmaceuticals. And in February of this year, they did the interim analysis and they announced that the study was a failed study and it was futile. They weren't going to get approval. And so now, and they spent over $100 million has been lost trying to make this drug into a medicine for PTSD. So it shows the challenges of phase 3, how much drug development costs, and now we're the only one left standing as a breakthrough therapy for PTSD. Next one, please. So post-approval, these are called risk evaluation and mitigation strategies, REMS. MDMA, psilocybin is not going to be like most drugs where once they're approved, they can be prescribed by any physician. So we are negotiating with FDA about this. What we're proposing, what FDA wants to see is that only people who have been trained by us, by the sponsor in the therapy can actually treat patients because the treatment is not MDMA. The treatment is therapy facilitated by MDMA. So the therapists all need to go through our training program. It's only administered under direct supervision in these kind of clinics settings. So it's never going to be a take-home drug. We may be able to treat people at home, but the therapist will have to go there to treat people at their homes. There'll be a centralized pharmacy that will ship the MDMA to this approved list of prescribers, doctors who, let's say, want to set up a psychedelic clinic. They'll have an abbreviated training program, but even the prescribers need to be through our training program. But if they don't want to be the actual treatment people, they'll just go through the shorter one. And then the patient registry. That's going to be a debate with FDA. There's a patient registry for esketamine, for GHB, Xyram. We think that there's a good chance they'll require us a patient registry. We're going to try to argue against it. And below the line is the FDA could conceivably limit people to 10 to 12 doses or so. If so, they'd need a patient registry, but we're not sure that that's going to happen. But these are the kind of ways that are going to control the use of MDMA post-approval. So it's nothing like medical marijuana. It'll be easy for the regulatory agencies to approve. Next slide, please. And we'll have a training program. The key part of us, and this is different than the psilocybin groups as well, is that we believe that therapists will be more effective if they've taken the drug that they want to give to patients. We don't require it. It's voluntary. We're not saying that everybody that's taken MDMA is a better therapist than people who've never taken MDMA. All we're saying is that if you're a therapist, you will be more effective if you've done the drug itself. We've gotten approval from FDA for 120 people, and we're in the midst of negotiations with them. I see a question about how can they limit lifetime 10 to 12 for MDMA, but other drugs are safe to take for a lifetime. Well, we would have to do a whole lot more safety studies, looking. So it would cost mega millions more for us to get. If the FDA did want to impose a lifetime limit, to prove that we don't need that is very expensive. And I really believe that if people have taken MDMA 10 or 12 times for PTSD and they still have PTSD, it's not working, and try something else. Okay, but then again, this is our therapy training program, and it's quite extensive. The last part E to C there is people working under supervision. And then it'll be in clinics like this. Next slide, please, as well. Or, So part E is just the last is that we supervise people working with a PTSD patient, our training team. Next slide, please. So it's just to give you a sense of the different kind of clinics that can take place. Next slide, please. So this is one of the things we're negotiating with FDA now. This is something that's going to be of interest to Compass, to USONA, to all others as well. FDA first approved our phase 3, where the lead person is a licensed therapist, or it could be a psychiatrist, and they've trained by us. The second person needs to be a bachelor's, and they're licensed to perform therapy or pursuing licensure. But the lead person for psilocybin, at least up till this point recently, has been required by FDA to be an MD or a PhD. That's ridiculous. It looks like they're being rigorous, but it's a complete misunderstanding of the training for MDs and PhDs. So anyway, this is a big point that we're arguing on behalf of the whole field to try to get it back to, of the 2-person team, just the lead person is a licensed therapist, and eventually the second person shouldn't even have to be on a track to be a licensed. Could be a massage therapist, a music therapist, a nurse, but ideally it would be a student that's working for relatively low money, because one of the issues is we do like the 2-person team. It's not twice as good as one person, but there's some expenses there. So if we can get the second person to be a student working for hours to get their therapy license, that would be really good. Next slide, please. So now I'm going to talk about the differences between nonprofit and for-profit drug development. I think a lot of the people here were investors. I think that's what attracted a lot of attention to this particular conference. But there are some differences. Next, please. And so the first difference, and I'd say in a way, access to capital is an advantage to for-profit businesses. Somehow or other, Mind Medicine has got a market cap of $150 million. And they can use their stock to buy all sorts of other things. We don't have that ability. So I think access to capital is one of you could say a good reason for going to for-profit businesses. However, next slide, please. If we demonstrate that we can make MDMA into a medicine, I think we, as Joe Green said in the earlier one, we may finally get traditional foundations even government money to support this. So Victoria Hale is a new member of the MAPS board of directors. She worked for 5 years or so for the FDA. Then she worked for Genentech, disillusioned with for-profit pharma. She started One World Health, got $160 million from the Gates Foundation to develop drugs for Africa, also India, parasites. But this is just to say that very large sums of money can come from the philanthropic sector for drug development. We've not been able to do that yet from these big foundations for psychedelics, but it may be possible in the future. Next slide. So while Victoria was working on the work with One World Institute, she got a call from Susan Buffett, who said, would you make low-cost hormonal IUDs for birth control? And she offered $60 million, and Victoria started Medicines 360. So these are the examples for us that it may be possible one day for large foundations to really step up and give us 50 or 100 million to make other psychedelics into medicines. Next slide, please. So here's another big issue, though, is that the data exclusivity that I talked about before, you don't need any patents. You don't need anything like that. But a lot of the for-profit companies do believe that they should patent things. And I am completely and 100% supportive of people patenting whatever original inventions that they make. I'm not supportive of the use of patents to block other people from doing things. So overbroad patents. I mean, again, if you patent what you invented, that's fine. Next slide, please. So there are process patents. So Compass has tried to patent the process for manufacturing psilocybin. They've made overbroad patent claims, and they've lost a lot of those under challenge. So I think that's not good. But I do think that they can patent whatever they've originally invented, and also that USONA will be able to find other ways to make psilocybin. USONA has actually already made their process information public, and that's what MAPS is going to do as well. We're going to publish all of the information about how exactly the medical grade MDMA was created. Now, in the 1986, when I started MAPS, Howard Lossoff started Ibogaine. He started a for-profit company, NDA International, to make Ibogaine, and that sadly devolved into a bunch. So we got a use patent, but then there was a bunch of lawsuits between Deborah Mash, Howard Lossoff, all sorts of things, and that really doomed the development of Ibogaine until that patent has expired. And so the core patent is for Ibogaine for opiate addiction. Atai has just bought a bunch of Deborah's patents for noribogaine and other aspects of Ibogaine. I don't think that will get in the way of what we're trying to do, again, because we're trying to do what the patent has expired. Mind Medicine now has bought data from Matthias Lichty at the University of Basel, and I'm not sure what they're actually going to do, but this was for LSD for anxiety, but MAPS started the research with LSD after 30 years in Switzerland, also with LSD for anxiety from life-threatening illnesses. So I don't believe that these use patents are very, well, if somebody comes up with a new use, I'm all for it. Again, patent it. But I'd be very concerned if people try to block Ibogaine for opiate addiction when that patent is in the public domain, or LSD for anxiety. And then again, because we are not concerned about patents or anything like that, we publicly post our protocols, our investigators brochure, the summary of the MDMA literature, all that's in the public domain. Next, please. So the other part of this is that the nonprofits, or Shlomi Raz talked about Elucis Benefit Corporation. He's actually where I first heard about Benefit Corps. So thank you very much for that, Shlomi. And so, as you can see, this idea of maximizing profits, maximizing social impact, and you try to find a way to get the most public benefit. And so that's a big difference between profit and nonprofit. Nonprofits are, or public benefit corps, are really maximizing public benefit, nonprofit. And next, here's a good example of something gone wrong, I would say, or go on, next slide. So this is esketamine, Johnson & Johnson and Janssen. So it's becoming increasingly clear to more people that when you combine esketamine for depression with therapy, you get better results. But what that means, because esketamine fades, people have to take lots of sessions of it. And sometimes people have done it for years, getting esketamine, either infusions or oral. But the problem is that when you combine it with therapy, the problem for the pharmaceutical company is people are going to spend more money for therapists and less on the esketamine. So they will make less money, but the other way with therapy maximizes patient outcomes. So I think that's one of the concerns about for-profit drug development, that they're not necessarily focused on maximizing patient outcomes. And we have the esketamine example as one of those examples. Next. Also, nonprofits and benefit corps tend to be more social justice oriented than for-profits. So next, please. So we are very interested in social justice. We just, this was the money we got from George Soros and then others, River Styx and Dr. Bronner's and the Libra Foundation, the Pritzkers, all combined to give us money for a training program for therapists of color. The psychedelic community is overly white. There's a lot of good reasons for that. I think that you need to feel relatively safe to be defenseless, and I think a lot of minorities don't feel safe. And there's also been a lot of scandalous research in minorities. So in any case, we have had to aggressively go out to try to train therapists of color. And so this was what we're trying to do. And so I think that's one of the other social justice aspects of it. Next, please. There's a group called North Star, northstar.guide. I'd refer you to it. They're a coalition of people who are trying to develop a set of ethical guidelines for how psychedelic medicine should go forward, safe, legal, affordable, equitable. And they're going to be announcing this pledge at the Psychedelic Liberty Summit, April 25th, but northstar.guide. And they put out a story that some of you may have seen. They call it Paula by the Oren Project. You can find it on the North Star website, and it's sort of a cautionary tale about an idealistic person who develops psychedelic medicines and then gets financial interest, then focus them in other directions, and they kind of lose their way. The Psychedelic Liberty Summit is going to be April 25th. Yeah, next slide, please. So this is about psychedelics, access, legalization, equity. It was, again, one of those conferences that's now gone verbal. It's going to be really, really interesting. Bia Labate is coordinating it, shakruna.net. And so you can check into the Psychedelic Liberty Summit if you're interested in another virtual conference. Next, please. Next. So JR was just quoted in Forbes. This isn't the 60s all over again. I want nothing to do with those kind of folks who want to decriminalize psychedelics. So I think what I'm trying to say here is that it's certainly within JR's purview. He said that he had to promise that he wouldn't do anything that was about recreational use. But I think that this is one of the differences between for-profit and non-profit. And for-profit is cautious. It doesn't really see the larger mission, which is really getting rid of the drug war, mainstreaming psychedelics, making it so that people don't have to necessarily get it from us or get it from medicine or religion, that they could do it on their own in a licensed legalization system. And so I also think that there's this somehow or other, those kind of folks who want to decriminalize psychedelics are somehow or other behind the pale, beyond the pale. There's something wrong with them. So I think this is a big thing. And I can understand both Compass and USANA are also staying out of drug policy reform. So it's not just limited to JR, but I want to say that MAPS is solidly supportive of ending the drug war, and it's not held us back with FDA or even, DEA hasn't been too thrilled, but they haven't been able to, it hasn't really stopped us from doing our research. Next, please. So not only are we very supportive of efforts to decriminalize, actually legalize and license legalization, Sarah Gale, who's the director of our Zendo project that does psychedelic harm reduction at festivals, Burning Man, elsewhere, she's actually on the Denver City Council board to oversee the mushroom policy in Denver and to try to do education of the police, education of the hospitals, education of the mental health services, so that we definitely want here in Denver, also in Oakland with decriminalized nature, potentially in Oregon, that we want to be helpful to try to do harm reduction in these areas so that as policy moves forward, it goes well, and then there'll be further moves in this direction, because we think it's a fundamental human right for people to explore their consciousness. The drug war is a violation of human rights. Next, please. So this is the Zendo project again. The harm reduction era, as I said. Next. This is just a chart of American attitudes, voters towards the legalization of marijuana, and over about a 50-year period, it basically shows things are flat for roughly 20 years, and then they start going up again in 1996, and that's when the California and Arizona started medical marijuana. So legalization follows medicalization, and that's one of the reasons why we have this medicalization strategy. Next. Now, this was a funny thing in Symposia. Christian Angermeyer's Atai Life Sciences position to take the psychedelic throne from MAPS. So there was a point a while ago where Christian was wondering if we would be interested in Atai investing in bringing MDMA to Europe and investing in what we're doing in the U.S. And I told Christian, no, I'm not interested in that at all. We're only looking for donations. And he said, why? And I said, well, first off, where were you the first 31 years that when we really needed money? Nobody was offering to invest anything. And then the other thing I said is that for the whole time, for the first 31 years, this did not make economic sense. No investors would do it. There was too much social opposition, too much regulatory problems. And so if we do make money from MDMA, I wanted to go to other things that MAPS would be doing that may not be ready for investors. And so Christian said, well, what's something like that? And I said, well, the most idealistic project that we have, the most difficult to monetize, next slide, please, is this project that we have with psychedelic reconciliation. And it turns out that there's groups of Israelis and Palestinians that are using ayahuasca together and using MDMA together underground, and but it's happening. And so we are doing a study like this in association with Robin Card-Harris and Lior Roseman. So it's MAPS, Imperial College University of Haifa. And so I told Christian, this is this project. And I said, it's a 3-year project. We've got the funding for the first year. The second year and third year, we don't have funding. But this is the kind of reason why we don't want to take investors. Investors are not going to pay for this. We want to make money from MDMA and use it for something like this. And Christian just didn't hesitate for very long at all. And he said, well, how much does that going to cost? And I said, well, it's 100,000 pounds in year 2 and year 3. And so Christian said, all right, I'll donate that. But he wanted to be the only donor to make it his project. Next slide, please. And so this is just one of the statements from one of the interviews that was from one of the ayahuasca sessions. Quote, there were moments of love and open-heartedness that we were all together. There is no you are Jewish, Arab, Muslim, Christian. Everything was stripped. All this nonsense was out, and only acceptance and love were present. So when Christian said, next slide, please, he said that he would donate the money, and he said, I'm not all about money. I'm about peace too. And so, Christian, that was phenomenal. That was the end of an article that that was about Christian, and I told that to the reporters, and that was the final closing point. And so I think for all of the others of you that are here, that are, well, actually, he donated $100,000 a year for 2 years. Here's the funny part. This article actually said that it was a 3-year project. And then Christian contacted me and he said, oh, it's a 3-year project. I'll fund the first year too. And I said, Christian, you forgot. I told you the first year is already funded. But since you're willing to fund it, if you would add that money to year 2 and 3, we'll be able to make those projects a little bit bigger. And then he said, okay, I'll donate that. So now we have even more money from Christian. That's another 60,000 pounds. And so I just want to encourage the rest of you who are investors to not be all about money, to be about peace, to support the nonprofit efforts, and also in your own for-profit efforts to really think about the larger picture. The earth is on fire. Humanity is facing massive crises. We're thinking about COVID, but global warming is an even bigger crisis. It will kill more people, displace more people. So we really need to all be thinking about the bigger picture. And so that's my last inspirational thing. And for the rest of you, this is the last slide, just to say that on Bicycle Day, the 77th anniversary of the discovery of LSD, that's coming up this Sunday. So there'll be from 8:45 to 5 in the morning to 5 p.m. Pacific time is this Sacred Solidarity with Spore, David Bronner's, MAPS, COSM, Queer Dome, and Zendo. And then MAPS is doing the Bicycle Night party, and you can learn about that at bicyclenight.org. So I look forward to questions. It's been a pleasure to spend this time with you all.
Wonderful. Thank you, Rick, for the amazing presentation.
Yeah.
We still have 141 people with us, so
Okay.
you kept everybody's attention and did a fantastic job. I'm going to jump right into questions here. We'll get a few off. I'm sitting on the floor now because I'm tired, but it's all gravy. We got Eddie Jacobs over here with the most upvoted question. And
That's a good one.
And it's
Okay.
coming. Where's Eddie?
I see it. No, I see it.
Yeah, go
Okay,
for it.
At the risk of ending on a negative note, well, first off, I should just say I like difficult questions. It would be great to hear Rick attempt a pre-mortem on the psychedelic renaissance. Suppose 10 years from now, as a movement, we have largely failed to live up to the potential we feel is ahead of us now. What do you think accounts for that failure? Or what are your biggest worries about the risks ahead? Whoa, very interesting. Okay, let's assume. So the things that would permit us to fail with MDMA in phase 3, I'd say the main thing that we're worried about is that there will be more suicides in the MDMA group than in the control group. There's no evidence that that's likely to happen. There's been no suicide attempts from anybody in our MDMA group. But I'd say that's the main one. But I'd say the bigger aspect of this question is I think if there's a lot of hype, if there's a lot of investors that tell exaggerated stories and take a bunch of money, make money on the stock, but the investors end up losing their money, that would make it, the whole field would look bad. But that would still not stop MAPS, Compass, USONA from going through what we're trying to do with MDMA and psilocybin. I'd say the biggest concern maybe is that I've seen some people have been sort of criticized. People do not have a higher suicide rate in the MDMA group. That's just what we're worried about. I just want to make that very clear. That's not happening. I'd say the concern that we have, again, would be a backlash. And where would the backlash come from? So I've seen people criticize me for taking funding from Rebecca Mercer. And I think that was one of the best things that I could have done. By building bipartisan support, we're minimizing the chance of a backlash. So I'd say, to summarize on this question, the main things we have to not do are to not exaggerate the benefits or minimize the risks. If you look what happened in the 60s, what happened was the government attempted to demonize psychedelic users. They basically exaggerated the risks and denied the benefits and then blocked the research so that there would be no benefits. But in response, Tim Leary and some others exaggerated the benefits and minimized the risks. and I think that led to disaster. There still would have been a backlash in any case, but I think that's the main thing, is we have to really be careful about being accurate about what we say the results are. It's just this one other question. Why is there an increased chance of suicide in the experiment? There isn't an increased chance. What I'm trying to say is that when people, we're one of the few studies with PTSD where we admit people who have previous suicide attempts. We do not exclude them. So the concern is just that people are severe PTSD and they're so challenged that and the emotions come up. It's difficult for people to process. So I'm not, there's not an increased risk. I'm saying that's the worry that we have. So, okay. So next question, Patrick, would you like?
Yeah, so we're going to go over to Jake here. Jake is a 20-year-old, and he is extremely passionate about the subjects and wants to work in the field. Specifically, he wants to know, how do you get into the field? What's a major you should focus on? Can you facilitate experiences with education, work with people on integration? He feels very zealous about dedicating his life to this work, but he doesn't feel like there's a clear path.
Well, there are clear paths. So there's so many different ways. You have to find out which way do you care about. So, for example, you could be a therapist. You could be a neuroscientist. You could run a psychedelic clinic. You could be a business major and be involved with psychedelic clinics. You can be an entrepreneur. You could be try to find and develop new psychedelics. There's multiple different ways, and the path will be each of those has its different paths. So we have our own training program. There's training programs that Compass and USONA have. So I think that really it's more about you figuring out where in the field that you want to be. And I'll say that we're going to need, I don't know, tens and tens and tens of thousands, 100,000 therapists. Yeah, you could be a mushroom cultivator. There's going to be an enormous need for therapists. And I'd say that's probably, it's a jobs plan. It's a growth area. That's, I'd say, the most important need. Because we can use new psychedelics, but we've got a lot of ones that already work and work great. And there are a lot of people that can do business and run clinics. So I would say the most important thing we need is more therapists. And at a 20-year-old, you got a lot of study to do. But really, it's what you're passionate about the most.
And I'm muted. And I would definitely agree with that. I mean,
okay.
If you're passionate about something and you chase that, you're gonna come up with some really great answers. It takes a lot of effort, a lot of failure, and a lot of trials, but you're gonna come up with the answer for sure.
Let me ask this other question I saw. This is this. Yeah. I'll answer both of those, but I want to go. If FDA is so supportive of psychedelics and it's not politics first, why is cannabis still a Schedule I drug and not recognized? It's because of the NIDA monopoly. It's because of the NIDA monopoly. Because GW Pharmaceuticals doesn't want the marijuana flower to be studied and compared to their own Epidiolex. I actually, years ago, tried to work with GW Pharmaceuticals and get them to, because they had the only license at the time other than University of Mississippi to grow flower. And they refused to sell us flower. They didn't want direct head-to-head comparisons of flower versus Sativex, which was the THC CBD combination. So it's about the access to the medicine. And so we have our own independent supply of MDMA. Compass and USONA will get their own supplies of psilocybin. Shlomi Raz has its own supply of LSD. But there is no domestic supply of flower. And at this point, there's no foreign company that has satisfied the FDA that they've got good medical practices, GMP cannabis that we can import. So it's really about the fact that the marijuana monopoly is the issue. The other question, I think, how does one become a psychedelic therapist without having a therapist degree? what would be the first step is their basic training. The first step is to have your own experiences and really learn from the inside out. And, but don't do it alone. Have friends there with you, preferably some that are not high to watch over you. And I think that, you learn through your own experiences. There's a whole archetype, Jungian archetype, called the wounded healer. Somebody that has learned how to heal themselves then has more ability to heal others. But then I think it would make sense to get a therapist degree. I don't actually have a therapist degree. My long-term goal is to become a psychedelic therapist and work full-time at a clinic on the beach in Florida and in Sarasota, Florida, where I went to college. And becoming a social worker, a clinical social worker, can actually do therapy. And so that's one way to do it. But I do think your own experiences and then more training. Okay.
Wonderful. And I would say let's take a couple more questions, and then if you're okay, we will transition into the Zoom link where we're all going to hang out and enjoy ourselves. So Symposia has a question here. Can psychedelics actually solve mental health without systemic socioeconomic change?
I would think that they go hand in hand. No, I think that I think we need both. I think that's a good question. I think that psychedelics can solve mental health among individuals. So yeah, we have taken people who have had PTSD and they no longer have PTSD. The work at Hopkins, the work at NYU, the work at Imperial College, they have taken people who have been depressed or anxious, and with psilocybin, they no longer have those problems. So on an individual level, psychedelics can be helping people with mental health problems. But we want really large-scale systemic socioeconomic change. There was a really excellent, well, this is a little bit more complicated. Let me just say that there's some social scientists who looked at deaths of despair. And those are suicide, alcoholism, and drug overdoses. And they noticed that in the counties that have more deaths of despair, there tends to be a higher vote for Trump. So that's not the only reason to vote for Trump, but still, these same people have just published an op-ed in the New York Times yesterday. Ann Case and Angus Deaton. It's called "America Can Afford a World-Class Health System. Why Don't We Have One?" And I'm just going to read to you the last line of their op-ed in the New York Times. Quote, "We are believers in free market capitalism, but healthcare is not something it can deliver in a socially tolerable way." And so we look at America, we have the highest per capita expenditures on healthcare, but our outcomes are down the 30 or 40 in the countries where we don't have very good outcomes because it's so inequitable the way it's delivered, and there's massive amount of money that's being taken for processing, insurance companies, things that's not directly healthcare, and a lot of profiteering as well. So I think the real question from Symposia about systemic socioeconomic change, I think that we need that as well, and that we hope that people who have solved their mental health problems will then go on and work on systemic socioeconomic change.
Great answer. Thank you, Rick.
I see what.
Maybe
I can do it super fast. Can I answer this one other question? How can I avoid an MDMA?
Yeah, we were going to go to that question for sure.
All right. Well, it says, how can I avoid an MDMA hangover? The answer is rest. I think about MDMA as a 2-day experience, and really the second day is for rest. Other people have done 5-HTP, stuff like that. We don't use that at all in our FDA studies. The FDA said before you do that, you have to demonstrate that there is this MDMA hangover, and we don't actually see it in our studies. We give MDMA during the day. We don't do it at night so people can sleep that night. We don't give it with alcohol or anything like that. And we encourage people to spend the night in the treatment center and also rest the second day. And so we actually find that in some cases, people in the control group are more anxious than people in the MDMA group because they haven't had to confront their trauma without the aid of MDMA doing the fear reduction. So I think the MDMA hangover is really just a matter of rest and maybe 5-HTP.
Just big R&R, rest and recovery. Let's take one more question before we. Honestly, I fully believe that we could talk about this all night. Rick, you have been outstanding. We really, really appreciate you coming on board last minute and your efforts, your keynote, and really thank you. Let's give the Rev the last question of the evening. Psychedelic treatment requires a lot of hand-holding. How can this be democratized affordably?
Well, first off is insurance coverage. There's two parts of it. One is insurance coverage. As I was trying to say, the arguments that we're having with FDA or negotiations about the qualifications of the therapy team. We want the second person ideally to be a student working for free. But the other big answer is how does this get democratized is through drug policy reform, through making it so in a system of license legalization, people can have access to it on their own, and they can do that with friends. I think what will end up happening is these psychedelic clinics will end up with therapists that are cross-trained in MDMA and psilocybin, in ketamine, and ibogaine, LSD eventually. So, but I think what will happen is the most difficult cases will go to the clinics. But we want people to learn how to do preventative medicine, how to heal themselves. That's where the Zendo Project and the peer support. So I think the real answer to this because I also don't think that we can minimize I don't think we can do this with robots. I don't think we can do it completely AI. There is a lot of interest in using technology to enhance therapy. But I think PTSD is a loss of trust in humanity. People have betrayed you. People have hurt you. I don't think you're going to get cured from a robot or from a chatbot. I think we're going to need people. And there's a lot of time that's going to need to be processing. We want to help people process it. So I think that the thing is really to work with FDA on the qualifications and then democratize it through legal access in a licensed legalization system.
You're an absolute legend. And you know what? Just because I'm a newfound lover of acid, we're gonna throw in one more question. And because who said it? Hang on. Somebody just said you've got Kevin. Kevin said, "I love Rick's enthusiasm for always answering as many questions as possible."
Yeah.
So one more for the audience.
I'm happy to do
on the after party. Is there any hope for eventually bringing LSD to clinical trials? What will it take to separate the stigma from the incredible potential benefits of the drug?
Well, the LSD trials have already happened, so we don't have to rely on hope. We did this study with Peter Gasser, and that broke the barrier of, LSD is the quintessential scary psychedelic. So it's the last one to really enter clinical research. Well, I'd say mescaline. Mescaline is the most important psychedelic that nobody's studying. But for LSD, what's happened is that Matthias Lichty has done a bunch of research with LSD, and we'll see what Mind Medicine does with it, because they bought his clinical data. I don't know what they're going to do about patents. I don't know what they can actually patent. But with their $150 million market cap, let's look to Mind Medicine to do clinical trials with LSD. But the main point is that even LSD, the FDA approved our study in Switzerland. So even though it was done in Switzerland, the regulatory agencies are open to LSD. And my first psychedelic ever was LSD, and I have a special fondness for it as well. I'm glad, Patrick, you've just got acquainted with it. And so I think there are certain advantages to LSD. Yeah, psilocybin is great. Psilocybin is a little shorter acting. It's more embodied. It's a little bit easier. There was one time Timothy Leary was saying that if they had never gotten to LSD and just stuck with psilocybin, they might not have got kicked out of Harvard. But at the same time, I think there's some advantages to LSD. It's longer lasting, which can be an advantage. It's truly remarkable and spiritual. And so I think the day will come where we'll have psychedelic therapy, and the psychedelic therapist will have a medicine chest of all the different psychedelics available to them, including LSD.
Well, I'll tell you what, Rick, I'm going to open up the medicine chest this weekend, and I'm going to do a trial on LSD, and I'll report back with my I'll let you know how it goes.
And if you need help with Zendo, there'll be psychedelic harm reduction in the bicycle night, so that people that are having trouble can contact people to help them with integrating things. And I will say, I see one more question, and then we'll go, which is, what do I think of 5-MeO DMT?
Why not? Let's go. Yeah.
Why not? Well, yeah, 5-MeO DMT. It's incredibly inspirational. I think it's very short acting. We need to learn a lot about it, but I think it tends to be more inspirational than therapeutic. It may be good for depression. I don't think it'd be that helpful for PTSD, although it's being used with Ibogaine, and near the end of the Ibogaine treatment, days after the Ibogaine is done, people get 5-MeO, and a bunch of Navy SEALs have gone down. So I think 5-MeO is something that really needs a lot more exploration to figure out how to use it.
All right, fine.
For the party.
Again too. Thank you so much, Rick. You're an absolute legend. I think the audience can definitely speak to how amazing this was. You kept people captive until 11 o'clock on a Wednesday night. If we're calculating for British time, we're hitting 4 a.m. Like, unbelievable. Thank you again. You were a last-minute addition, but you were a cherry on top of what I hope everybody believes was an excellent conference. We're going to definitely take a lot of these learnings. We're going to apply it to the next one. And Connor's going to go ahead and hit you guys up with the Zoom link for the after party again. If you're awake and you feel like joining us, feel free. We'll be there in about 5 minutes, and thank you so much for an amazing day. I'm just going to go ahead and mute our cameras and audio so that the link stays there, and we'll catch you guys on Zoom. Thank you so much.
Great. Bye, everybody. I'll see you soon.